Welcome back, everyone. Kasha Singh is an infectious diseases physician at Royal Melbourne and the Doherty, and is going to give us an update on monkeypox, having alerted us to it last year.
Yes, yeah, that's right. Okay, thanks for inviting me to speak. I do science as well, but I'm predominantly a clinician, so a lot of this will have a bit of a clinical focus to it. There is a lot to talk about for monkeypox. I've picked and chosen a little bit from what's available at the moment to focus on a couple of key things that I think are important. Firstly, I think it's important to highlight the changing nomenclature. Most recently, we had a renaming on the 28th of November when we moved into using the name Mpox as a new name. There's a transition period supposedly of about 12 months, but we are now actually Mpox rather than monkeypox. The clade names, previously known as Central African and West African, are clade 1 and 2, and of course the current predominating circulating strain in most of the 2022-23 outbreak is clade 2B, so subclade. There's also a whole lot of people writing things about the wider use of language in descriptions of what's happened with monkeypox, and in particular the use of preventative or pre-exposure prophylaxis versus primary preventive measures, and the language around describing groups at risk and transmission, which I won't go into now, but I will reference you to a couple of important papers on this that are really worth having a look at, just thinking about how we use language in these situations and what we might or might not have learned from past experience in COVID, but also around HIV. One of the things that I think more recently we've been able to do a bit better is understand what's happened in the past and frame the evolution of monkeypox in light of what's happened now, which helps us to understand a bit better what's going on, I think at least, and is counter to some of the hysteria that surrounded the first appearance of this. I think if we understand this better, it can help us deal with what's happening now. In the early cases, we know that this is very incomplete reporting, but I've sort of graphed it here just to give a bit of an idea and just to orientate you. This is 1970 onwards, and case numbers are based on the reports that we have. It's a logarithmic scale of numbers on the y-axis. The x-axis is time in about 10-year intervals. The red or orangey coloured shapes represent clade 1 or the Central African Congo Basin strains, and a number of cases of those over years. Different shapes of different countries. The predominant countries, the red one, which is the DRC, previously known as Zaire, and the blue are those cases representing, or those countries with cases representing that are clade 2 or the West African strain. And of these, Nigeria is the predominant one to look at, but also cases in Liberia, Sierra Leone, Cote d'Ivoire. So an early publication established that having had a previous smallpox vaccination did reduce your risk of a monkeypox illness or reduce the severity of the illness. Illness or infection were less common in people who were vaccinated, and that was estimated at about 85%. And in current cases, we're seeing similar things. I thought this was a nice slide, also representing similar information for that first couple of decades of identification of cases. This was presented at IAS in Montreal last year, and it shows the rainforest sort of region of Central and West Africa. And in the blue, the West African or the clade 2 cases, and in red, the clade 1 cases, and where reports were available from those 2 decades in different places. They're all around the rainforest region. Many of them were in children, and the genders were equally represented. The source of infections was thought to be wild animals, and most of the occurrence of cases was in small villages, so not in big urban centres. So this is again going to the graph, and you can see cases in the DRC are really dominating in the next decade. So at the top, you can see maps representing the different decades and the cases and numbers. Sorry, but the blue squares are used to identify the West African or clade 2 strains occurring. And there are actually very few of those. In 1990 to 2000, there were none reported, and most of the cases were in the DRC. In 2000 to 2010, the main thing really here is, again, there's no West African cases, but there is an outbreak that occurred despite that. an outbreak that occurred in the US in 2003 was actually linked to the importation of an animal from Ghana, which has never recorded cases, but the animal was affected by monkeypox or mpox of clade 2, ended up passing it on to American animals, prairie dogs in this case, and all human cases were related to contact with the animals. So this is the first excursion of cases or identification of cases outside of an endemic area. And it's interesting to see how that sort of happened, what happened and what didn't happen. There wasn't human-to-human transmission. All of the cases were from the prairie dogs and not the other affected animals. And it was thought that the prairie dogs might even act as an amplifying type host. When they tested all the shipment of animals that were shipped at that time, many of them had monkeypox detected in them. So it's interesting, as much as anything else, to note what didn't happen there, which is you didn't get a whole lot of other cases. There was a ban after that, though, of importation of African rodents to the US. There is an interesting paper looking at the natural reservoir and questions around it, which has been raised in the recent outbreak. That 2003 outbreak in the US is key in this discussion. But there's also a few other outbreaks that are referred to, a 1964 outbreak at Rotterdam Zoo. And you can see, I think the thing to look at there is the range of animals that were affected there, but also not just the range, but the paper also considers the different manifestations in the different animal groups, some of whom got sick, some of whom had no manifestations, and some of whom died. So different animals seem to be variably affected. Antibodies and virus detection in so many different species seem to suggest that the natural life cycle is a complex interaction of reservoir hosts and incidental species, and which of which is not really known at the moment. That paper also discusses the potential role of insects in the natural lifestyle of monkeypox, making it even more complicated. So from 2010 onwards, we do get a resurgence of cases of clade 2, so the West African clade, and in particular in an outbreak in Nigeria, which started around 2017. And you can see the diamonds in dark blue increasing there, but also a smattering of cases also of that West African strain. And along with that came a few other excursions. So Israel, Singapore, and the UK all had additional cases, mostly associated with travellers, and additional travellers were seen in the US. These were confined. There was only limited onward transmission during this time, but they were well recognised and different to previous decades. And on the background of that and that increase in cases in Nigeria, as well as the DRC, we had our outbreak declared on the 21st of July. And that was started in about May, with cases first in the UK, the US and Canada, and a lot of other European countries. And a lot of these were thought to be linked to people who attended an LGBT plus pride event that was held in Gran Canaria. And that was initially linked to a lot of the transmission chains in several European countries, although independent transmission has been recognised since that time. So this is where we are now. You can look at the epidemic curve there and see what's represented. And again, it's sort of as interesting to note what's not represented as what is. We've got a lot of countries, a lot of cases around the region of the Americas and the European region, and the African region still only just up the top level of those graphs. I think one of the most important things to think about here is capacity and testing and what is going on in the way of resources around testing and diagnosis in different parts of the world, which has probably been a bit of a theme about this disease for a long time. Going on, this just looks at the different regions, the World Health Organization regions around the world, looking at the different case trajectories in different parts of the world and how they differ. And we've really seen quite different patterns in different places. The reason for that's not completely understood. And in the past 7 days, 13 countries reported an increase in weekly cases. The highest of those was in Mexico. And 71 countries, including Australia, reported no new cases in the past 21 days. The total has gone up a bit, 91 deaths now, but over 80,000 confirmed cases. What about locally? Well, this is Australia. On that, on the far side is the whole of Australia epidemic curve there. And on this side is Victorian cases by mode of transmission. The red are from travel overseas. You can see that's a fair number of cases with some limited local acquisition and transmission. The most recent case, November last year, was overseas acquired. Hospitalisation has been required for symptom management in some of these cases, and antivirals have been used, and we haven't had any deaths. So the population risk in 2022-23, most patients have been diagnosed with Mpox amongst the MSM. They've reported high-risk sexual behaviour as a potential risk factor. They've reported other particular high-risk behaviours, including multiple or anonymous sexual partners, group sex sessions, recreational drugs during sex. There's a lot of concomitant sexually transmitted infections reported in these cases, so up to 30% in published cohorts, particularly gonorrhea, chlamydia and syphilis. And there is an overlap in some of the presentations, in particular syphilis with the rashes, and I'll talk about that a little bit later, in some cases being a little similar. 30% are on pre-exposure prophylaxis, so PrEP, to prevent acquiring HIV, so sexually active HIV negative adults, and as many as maybe 40, 50% in some cases are people living with HIV. But case series so far haven't showed a significantly different spectrum of illness amongst those people living with HIV if they're on treatment and have viral control. Australian surveillance data, the case definition of a confirmed case is the same across a lot of countries in the world, and it's based on laboratory definitive evidence. And again, this the flow-on effect of this is it influences how many confirmed cases you can get if your reagent supply is low or if you don't have access to facilities to be able to test and provide that definitive evidence. Probable cases use less specific detection methods for orthopox viruses generally, rather than specific to Mpox, and in the combination of clinical evidence. So compatible rash or lesions and various other more general symptoms like lymphadenopathy, fever, headaches, myalgia. A suspected case requires clinical evidence and an epilink, so some sort of epilink, the details of which in red are the ones that have changed, so that evolved as with our evolved understanding of what has been happening here. So individuals at social events that are associated with monkeypox activity, and these events are further defined in point 6. And the addition of or inclusion of proctitis, so painful inflammation in the absence of externally visible rash or lesions, is now included as a potential criterion for clinical evidence of infection. So what's been happening, representing here what has happened with the African number of cases during 22 to 23 compared to what's happened previously. And you can see with the crosses, countries which haven't had previous reported cases compared to the same shapes used for countries that have the number of cases in Nigeria, sort of around the same, and the DRC around the same. So it's hard to know what this means, but I suspect it means that we're not testing. We're still not testing in those regions as much as we are in other parts of the world. So what do we know about the clinical presentation? Previous reports are pretty sparse about what it was like before. So the idea of this is completely different to what we'd seen before is not based on that much evidence. And when you look a bit more closely at the reports, it's not too far different from previous reports of clade 2 virus infection. Previous reports of clade 1, they're small, they're probably not representative, and they're incomplete. So incomplete assessment of cases. And you can see the numbers there, 282, 122. Recent reports have been predominantly amongst from sexual health clinics and MSM, so we've got lots of details about those cases. And the WHO, the World Health Organization, detailed case data provides the biggest range of data, but is a bit limited and also limited by ascertainment bias. So you can't get a denominator for percentage of cases or percentage of symptoms. But this is the overall data, the most up to date. So still mostly men, 3% female, a few pregnant women, not that many, and very, very few children are being affected, and significantly very, very low exposure in school settings, which is something that was worried about for a while there. 48% HIV positive, thought to probably be skewed towards those with positive results who answered the question. 1219 cases reported in health workers. Again, transmission within a health worker setting is probably very, very low. So most of these are acquired in the community. Sexual encounter was the most commonly reported transmission, and most common setting was in a party setting with sexual contacts. This is the World Health Organization data of the cases, and you can see any rash here, 79%, and the limitations in data collection, some of those are listed on the left. So does this really differ from previous cases? Previous cases describe are mostly dominated by clade 1 descriptions and describe a much more generalized illness that's very similar to smallpox. So a rash starting on the face predominantly with a significant prodrome 5 days or more before onset of the rash, which then progresses in a fairly predictable way. So moves from the face to other parts of the body, including the palms and soles. Different from chickenpox because you get lymphadenopathy, and the distribution of rashes is absent on the palms and soles. There's a shorter prodrome, but very, very similar to smallpox, apart from the lymphadenopathy. In recent cases, we've seen transmission to intimate contacts and MSM in particular. The prodrome has been less prominent, might be absent. The rash may predate systemic symptoms and may be atypical, so-called, with genital lesions being common, multiple stages at the same time, and non-pustular lesions being common. Complications largely relating to pain, so rectal and penile lesions, pain with proctitis, urinary retention, urethritis, a few bacterial secondary infections, and encephalitis, occasional cases around the world, some of which have been associated with mortality. There's been a question raised about asymptomatic infection, which I'll go on to, but firstly, I think one of the other important things that's come up is the range of differentials that can be, that should be considered with various different monkeypox presentations. And here in the blue boxes, the first and third column represent cases of actual monkeypox, and the second and fourth columns are various differentials, which look very similar, as you can see. So in particular in dark skin, in distinguishing some of the so-called characteristic features can be very difficult. So you've got here things like varicella impetigo with scabies, a primary syphilis chancre, ORF, dermatitis herpetiformis, molluscum contagiosum, an HSV ulcer, and an aphthous ulcer, all resembling very closely actual monkeypox presentations. It is interesting in that sort of context to look back at the most detailed description of the Nigerian outbreak, so clade 2 again in 2017, where some similar things were described as what's being described now. So genital rash, rash without fever, spread to urban areas, more cases amongst men than women, older, so no longer predominantly amongst kids. Many cases there, however, were unconfirmed, but there was some generations and transmission. So again, different to what's been seen before. And what's been seen before in clade 1 is described, bigger series in the first column here, and you can see much younger individuals where most are less than 10, compared to subsequent descriptions, including of the current outbreak, where the age is sort of 30 to 40 or 29 in one case. Men predominant, lots of concern about sexual transmission. People living with HIV are affected commonly. In the clade 2 report, I guess the main thing about people living with HIV is a large proportion of those that died in that case were significantly immunosuppressed and living with HIV. Prodromal symptoms varies a little bit, and that's thought may be related to different routes of transmission as well as virulence factors differing between the viruses. But systemic features are still seen in a fair proportion of cases that we're seeing now around the world as part of this outbreak. A rash is seen often, the distribution of the rash is different, and deaths are significantly different to what's been seen before. So asymptomatic viral shedding was thought to be a big factor. There are a couple of reports that came out in the middle of this year. There have been follow-up reports from those which suggest it's probably not as big a factor, but there is seems to be a significant risk for transmission in the sort of prodromal period or the pre-symptomatic phase. And so the role for screening has come up. Modelling studies suggest that in this outbreak, about half of the transmission might have occurred in the pre-symptomatic so-called phase rather than asymptomatic as such. And deaths, well, so far about 91, there's the distribution. We don't know very much in detail about the small number of reported deaths globally, but it's about 0.1% of the total number of cases. And these are some of the details of what we know. Essentially, a lot of them are significantly immunosuppressed individuals, and there are reports of encephalitis. I'm not going to go probably into detail about this. It just describes different methods of what we think now about transmission and pathogenesis. So different methods of acquisition of the virus, respiratory droplets seen particularly in clade 1 in the past, and dermal inoculation, and the likely differences in pathogenesis of disease in those two methods, which may explain the different clinical manifestations that you see. And this was recognised partly in the 2003 US outbreak, where the mode of transmission or site of inoculation was thought to be very important in influencing what the disease manifestations were. And treatment and vaccination. So tecovirimat, the antiviral that we have access to here as part of a national stockpile, does inhibit an orthopox virus protein essential for dissemination within a host. There are no trials and efficacy in monkeypox, mpox. Non-human primate models show that it improves survival, and case studies in humans show anecdotal improvement of symptoms. We do have vaccinations, not thought necessarily to be required universally, but following exposure for those at high risk. I think the main thing about these treatment and vaccination is, of course, access again. So access to these is extremely limited in parts of the world where the disease has previously been a problem. And a summary slide, monkeypox is changing. Probably there are differences in what we're seeing now, but it may have also been changing for some time, and there are significant knowledge gaps in our understanding of the disease in Africa, where it's been for some time. Symptomatic infections are generally self-limited. Supportive management's all that's needed. Treatment of complications and antiviral therapy are there for us, but not for everyone, and the immunocompromised may be at particular risk. There are more research gaps than I'd care to mention here, and a lot of space for things to be done to improve both global response consideration of a One Health approach, as well as looking at natural history. Thanks.
Questions, please. So how's it set up in Melbourne? Do we have a sort of a central referral source, or?
Well, we don't really now have there was at one stage, but I don't think anymore there's necessarily one place to refer to. And I think the bottom line is most cases haven't required admission. So access to tecovirimat through the national stockpile, so we all have to apply for access. And a lot of the cases were referred, I think, to a couple of central hospitals initially, but many of them can be managed as outpatients.
Yep, thank you. Yes, Rod.
Yeah, thank you. Long-term protection, immune response, and are they going to get it again?
Yeah, probably not. It's probably good.
You need to talk to the microphone, sorry.
Not. It's probably good as far as we know, but long-term data is lacking. So in people who've had previous vaccinations, it looks like they've got some protection, but they can certainly get infected. So who had smallpox vaccination in the past, and we're accumulating evidence for people now. There's particular evidence that you can get infection in the time, so shortly after a vaccination, before you've had ideally you need at least 2 weeks to get some immunity. And so there's definitely cases that occur in that period in between. But people who've been vaccinated don't seem to get severe illness. But the other questions are open. There is work being done, but not really controlled work. It's more studying people who have been vaccinated.
And education, is it for the healthcare workers or is it for the at-risk population, or both?
It's probably both. It's interesting. So with those recent figures, the updated figures in Victoria, we haven't had recent cases and rates of vaccination are plummeting. We have got Pride coming up in Sydney soon. There are increasing cases of things like Shigella imported from overseas. So we know that there's transmission of other things, and when awareness appears to be sort of going down, and that may cause problems. So whether that's coming from healthcare workers, I know that during the time of when we were having increasing cases around the world, a lot of MSM, other people who perceive themselves to be at risk were coming forward requesting vaccination. And at the time we had somewhat limited supplies. We have lots of supply now, and there's less people coming forward. It's been our experience.
It just reminds us all that viruses are incredibly important.
Yeah, I think it would be good if we could. It's interesting looking back, because there are a lot of there is a lot of awareness around people who knew that things like this could happen, but still a really big deficit in resources that went into looking at that more closely. So it does feel like we should be maybe a bit more aware and be able to distribute resources for investigating these things a bit more equitably.
Yep. Yep.
One Health and that.
that the vaccine was licensed as subcutaneous, but it's now accepted on the basis of one small paper and equivalent neutralizing antibodies, which we're not sure are actually protected, is we're all doing intradermal, and I'm one of the people that advocated that, but I think it is interesting that it's now sort of accepted as a public health intervention here because of the supply problems.
It would be great
essentially.
if in parallel we could be studying these interventions as we do them so that we can, have that data. It's been a bit frustrating that we haven't been able to do that.
Absolutely, yeah.
We'd love to.
We're trying to set that up.
Yeah, well, we're fully supportive. We'd like to be involved.
This monkeypox task force can, just picking up on what Kasha said, there's a big push to vaccinate before World Pride, and it's difficult. And there's a huge social media campaign and a lot of activity, but uptake's really dropped off, and we're still trying hard in that space. So we'll see what happens at World Pride. Hopefully there's not much of a problem. That'll be good.
And do you think, is it stigma or apathy, or what would be the major barrier?
It's the epidemic curve. Like the behaviour change is probably the biggest factor at work. We have a very good communication strategy. The numbers dropped off massively quickly. Whether vaccination was some of that, who knows? But
This is the problem because we haven't studied things well. Don't know.
We don't
but
know.
Got
Yeah.
this decrease, got all these things that happened, and it makes it hard to talk to people about
But
it.
we're still trying to encourage people at risk. I think certainly, but leading up to World Pride, that's millions of people coming to Sydney. Some incredible number of people. So, yep.
Kasha, thank you. It's a very important area.